Good morning. Can people hear me?
Yes, we can hear you. Thanks.
Very good. Thank you.
All right, good morning, everyone. I think we can go ahead and get started. On behalf of the Division of Healthcare Financing and Policy, Electronic Health Information Advisory Group, I would like to call the meeting to order and verify that this meeting is being recorded. Angelica, can you please confirm?
Good morning, Melinda. The meeting has started being recorded. Sorry about that.
Great, thank you so much, Angelica. All right, so today's meeting agenda for the Electronic Health Information Advisory Group was first posted on May 29th, 2024 on dhcfp.nv.gov and at notice.nv.gov. So we will begin with the roll call. Dr. Eddie Ablezer.
Present.
Great, thank you. Sarah Bradley. Okay, Eileen Colon. Kathy Denauer.
Present.
Thank you. Michael Gagnon.
Present.
Great, thank you. Brooke Greenlee. Maya Holmes.
Here.
Thank you. Ashley Jonke.
Present.
Thank you. Michael Kennedy.
Present.
Thank you. Dr. Christopher Lake.
Here.
Thank you. Lynn McAllister.
Present.
Thank you. Quinn Polly.
Present.
Thank you. Katrina Peters.
Present.
Thank you. Chuck Podesta.
Present.
Thank you. Dr. Mark Rosenberg. Dr. Jonathan Salinas.
Present.
Thank you. Dr. Vila Sastry. Andrew Topper.
Here.
Thank you. Dr. Darla Zarli. And Lei Zhang.
Here.
Great, thank you. And I want to move on to our ex officio members. Sandy Rubelit.
Present.
Thank you. Shelley Aguilar. Melinda Southard, I am here. Lisa Latrice. Here. Thank you. Dr. Anilkumar Mangala.
Yes, present.
Great, thank you. Cody Finney.
Present.
Thank you. Scott Kipper.
Here.
Great, thank you. Russell Cook. I did know he did tell me he wasn't going to make it today. Celestina Glover.
Here.
Great, thank you. At this time, I want to check in with Angelica. Can you please confirm if we have quorum?
Good morning, Melinda. We have met quorum.
Great, thank you so much. All right, so now we'll move on to review and approve meeting minutes from the previous meeting held on May 2nd, 2024. I will entertain a motion to approve the May 2nd meeting minutes.
I'll make that motion, Michael.
Great, thank you, Michael. Do we
I'll
have a second?
I'll
Great,
second.
Thank you so much. All right, we have a motion and a second. Any discussion? All in favor, please say aye.
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 Aye. Aye.
All opposed? Great, motion passes. Thank you so much. All right, so now we'll move on to agenda item number 4, public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. If you would like to provide public comment, please raise your hand utilizing the Teams platform. Or if you are calling in, please press *5 to raise your hand. And I will pause now for public comment. See, Michael Gagnon, your hand is raised. Please go ahead.
Thank you, Maya. Yeah, I'd like to make a public comment. I want to thank Melinda, Gabe, and the whole Electronic Health Information Advisory Group for their outstanding work on creating so far, as quoted from AB7, a framework for the electronic maintenance, transmittal, and exchange of electronic health records. I think it has become quite clear during these deliberations that the concept that a true framework for interoperability in Nevada can be accomplished solely by patient-directed exchange and provider EHR connections to a national QHIN network under TEFCA is naive and will not meet the requirements and have a major negative impact on providers and patient safety. Now, I'm not saying that both of these capabilities are not important parts of a fully functional interoperability framework, but alone do not solve the problem. As the group has worked through the proposed regulation, we have touched upon the value of these capabilities, but also addressed how medical records must be shared with emergency rooms, lab results delivered to providers, and alerts on patient admissions to emergency rooms and hospitals must be handled, as well as providing public health or population health initiatives, which depend on aggregated data, not data siloed in electronic health records. Another major challenge is that TEFCA QHINs qualify as HIEs in Nevada according to AB7, and thus must be certified by the state and comply with all provisions of AB7. That means that they must manage state-based patient consent, because the data use and reciprocal support agreement signed by all participants in any TEFCA qualified QHIN network specifically states the patient consent is not managed by the QHIN, but must be managed by the participants in the QHIN. The implications here are pretty significant. Is that all healthcare organizations in the state that are currently connected to any national network or QHIN must now stop sharing data over any non-certified network and must develop in conjunction with their EHR vendor the ability to manage consent to release the information to another organization. I think that has been lost on some folks as we go through this process, the complexity of what that means and how that has to be managed. Honestly, there's a reason no other state with a successful interoperability framework or network has taken the approach of a patient-directed exchange and TEFCA QHINs as the sole solution, because it does not fully address the problem. The excellent work that Melinda and the advisory group have done to create this robust regulation is designed to enable true interoperability, which will save lives and reduce costs. The public comments given by the Culinary Union Health Fund would accomplish exactly the opposite.
Thank you, Michael. Do we have any other public comment? Okay, seeing none. I'm sorry. Eddie Avalizer, please go ahead.
Sorry, Melinda. I just wanted to, is this the right time to ask? I know I sent you something that I finalized over the weekend, but are we going to be getting into some language development later in the agenda?
Yeah, I'm going to go section by section. I'll describe that in the next agenda item.
Okay, I'll reserve my time. I did want to introduce the data protection language that I was hoping that the advisory group might consider.
Great, thanks, Eddie. Yeah, we can go through that in the next section if you would like.
Great, thank you.
All right, any other public comment? Okay, seeing none, we're going to move on to agenda item 5 for possible action, presentation and discussion of draft health information maintenance, transmittal and exchange regulations. So moving forward from the May meeting discussion and votes, I've provided you all with a clean version of the regulations to review today. I did keep the lettered sections intact for simplicity of calling out specific sections of text in the draft regs, and I kept blue italics text to note overall new language additions to date from the original regulations, and the red strike-through text to note any language removal. In going through this action item today, we will plan to, again, go section by section, similar to how we went through the document during the last meeting. We will review each section where there are proposed changes and have a discussion on the construct of the language. So at any time during the meeting today, this is also your opportunity to request any additional revisions to any part of these draft regulations that perhaps we had not discussed before or that we have discussed. Following that conversation for each section, I will then move to the next section to ask for discussion. Once we've gone through each section and get to the end of the document, having made any necessary revisions or updates based on today's discussions, I will ask then again if there's any further discussion on any of the sections or the document as a whole. Following that, I will plan to call for a vote on the entire document. As a reminder, our output goal from this meeting today is to have the final draft regulation recommendations from this group approved for me to then present to the DHHS director for review prior to submitting to the Legislative Council Bureau to initiate the path for permanent regulations, all prior to June 30th. Additionally, I do want to call out that although not part of the formal regulations development process, these regulations should go before the Joint Interim Standing Committee on Health and Human Services prior to seeking final approval from the Legislative Commission. So with that, I just want to pause. Do we have any questions before we get started? Okay, so I'm going to go ahead and share my screen. Okay, looks like we should be good there. Okay, so the first section is section A, definitions. So as a review at the top here, we included the addition of maintenance and transmittal language to better align with the title of these regulations with the requirements set forth in Assembly Bill 7. This section contains all requested new definitions based on discussions from this group's previous 3 meetings. We've added new definitions to these regulations to include interoperability, provider of healthcare, electronic health record system, health information exchange, and person. And I will pause here for any questions or comments and ask that folks to review the language. And please speak up if you have any questions, comments, or concerns on the definitions section. Okay, seeing none, I'm going to go ahead and move on to the next section. So the next section is section B, requirements number 1. As you can see here, we have quite a bit of additional language based on our previous discussions under the sections in item 1A here. And then down in items 1H through M. And so I'm sorry, I tried to make this as big as I could so that you could read it, but it doesn't all fit on one screen. So again, I will pause here for a moment, giving members a chance to review the language and ask that you all have, if you have any comments or suggestions, please feel free to speak up. And Eddie, please go ahead.
Yeah, Eddie Alliser for the record. Melinda, would this be the correct place? Because I know we're talking about the security of that information in J. And I'm looking to you and staff to determine when's a good conversation around security. Looks like this might be a decent place for it, but
So Eddie, clarifying question, the security, is it related specifically to the health information exchange that is part of this section here for the requirements?
I think it's probably related to the data itself, the consumer data. So
Okay. Do you by chance have a copy of the draft language that maybe you could share? I could stop sharing and you could share your screen so members can see.
Absolutely. Let me pull that
Perfect.
up.
And even if it's not the right section here, we can always figure out where it goes. So that's fine.
Absolutely. And just by way while I'm doing this,
Can I add a comment at this point that might help you, Eddie? The Health Nevadas have been the only organization that's gone through the state certification process for health information exchanges. And we've been through it twice and are in the third phase of doing that. The first time the state asked us to comply with a federal program, or not a federal program, but a national program for security and privacy, and we went through something called ENAC at that time. And since that time, we're now certified with the highest security accreditation you can get, which is called HITRUST. I think that honestly, it covers a lot more than what the language you're having here, meaning it's very extensive. If you wanted to put the requirement for a HITRUST accreditation more specifically, I think honestly it would cover, I think, everything you're talking about and then some. Would that meet what you're thinking about?
So let me just sort of ask the team what this is. Can everyone see this? Because on my screen I just see my own
yes
document. Okay.
Yes.
So I had a colleague who works in the cybersecurity space, particularly with, this is CISA, and I could pull up CISA for all of you if you're interested. Let me see if I can drop the link in the chat. But CISA is the U.S. It's the U.S. Cybersecurity Infrastructure and Security Agency, I guess. It is I think the guiding principles for business, anyone that interacts with the electronic health record to some extent. And so, Michael, one of the things that came back to me was that perhaps using the CISA guidelines helps with all individuals, all, I guess, touch points of that data record. And rather than totally prescribing things, what they provided is sort of these I wouldn't call them vague, but they're general principles. They're, they're these performance goals, as they call them. And these performance goals are, I think, widely accepted for everyone to protect the record. And so I am concerned. My only response, Michael, is I'm concerned putting into regulation some sort of accreditation, like calling that out. I know that sometimes when we put in a vendor accreditation, it creates a lot of concern. So I was thinking just core principles, and these I think are the most widely accepted core principles or performance goals based on CISA. And I'm going to try to find out more.
I tend to agree with you. There's several others we might put in here. I was security officer at a large health system at one point. So like, yeah, I think you have it. These are right. I think that might be better in the certification process though, rather than having to be in this regulation. You know what I'm saying? That because we go through this and it's extensive and far beyond, even what's said here. I don't know if Sandy wants to weigh in on that, because I think she's helped us through that certification process before. So I'm not saying they're not right. I'm saying it's great. I'm just saying I think they probably are covered and then some in part of the process that's already in place.
Can I just interject back? And I know a couple other hands popped up, but Michael, wouldn't this also, I mean, it's all users or all touch points of the record, right? And so
Yes.
I mean, technically not all providers are going to be have to go through those types of high level credentialing, right?
No, they don't. Not with on their electronic health records necessarily. Although most electronic health record vendors are HITRUST accredited now, so that's that's also become a little bit of de facto accreditation standard, I'll say, in the industry. And NIST covers some of this. You get into the National Institute of Standards and Technology. But if you pull it all together into kind of a security framework you can comply with, there's really two in the industry, ENAC and HITRUST. And HITRUST is the one in healthcare that almost everybody is kind of attaching itself to. And I think during the process, like I said, through the certification process, all of these and many other things are covered.
And I'm wondering too, Michael, so you had said the certification process, so that's with an HIE, but if we have, we want to make sure that these encompass HIEs and EHRs, right? And so would it be appropriate to add this type of language in section B as like an additional section that would cover both entities?
Yeah, or any other business associates attached or anything like that are on the fringes of it. It has broadened this to include electronic health records. Again, the vast majority of them are, but not necessarily, depending on as you get into smaller ones, and it becomes a little bit more a requirement of the medical practice to follow HIPAA standards around this as well. So, and then they're covered a little bit in HIPAA as well. So I just wonder if we need to be explicit or are they kind of already embedded in something else?
Right. Good question. I do see we also have Michael Kennedy. Your hand is raised. Please go ahead.
Yep. So I might be echoing a little bit, but this is a very good basic list. I mean, we might want to put in something about encryption standards along with it, just kind of for general security. But whereas I like the idea, kind of like the other Michael was saying about having like a requirement for accreditation like HITRUST. We have run into the past that smaller, newer vendors or partners might not have the time or resources to get that accreditation, even though they can show that they have similar controls in place. So it just may hurt some of the smaller providers. But it does make, approving them much easier. So there's good positives and negatives.
Sure. Thanks, Michael. And
I
then,
wonder who this would apply to is in what you were thinking, Eddie. Well, who would this apply to? Like, would it apply to the providers and hospitals? Would it apply to the health information exchanges? Would it apply to, you know, I'm kind of
Yeah.
struggling with where it fits in this
Oh.
to make sure that it's at the right level.
So, I mean, the guidance that in talking really touch points, right? So whenever that record is maintained, is transferred, like any sort of touch point, so that is the provider, it could be the hospital, it could be, and I'm fully aware that these are, I think, the guiding principles set forth by CISA to many operating facilities. I feel like calling it out, putting it into reg is a good baseline that guides us, perhaps. And I'm definitely not as well versed as Michael and you, both Michaels, on the call on this. So I'm definitely comfortable moving this around. This was, again, someone who's really familiar with CISA that shared, let me be clear, they shared it to me in a way that didn't really fit regulatory language. So I had to nuance it the best I can. So I think there's probably stuff in here missing, but it's all of those touch points in what I was thinking.
Great, thank you. I do want to recognize we have several other hands raised, so I'm going to go through the list. So I've got Maya Holmes, please go ahead.
Hi, good morning, everyone. I just want to echo, I think, supporting having the more general principles versus prescribing per specific entities or vendors or credentialing. I just think this is going to evolve over time, and the issue of having the different touch points and different providers versus different facilities and their capabilities, we should be supportive and recognize that. Thank you.
Thank you, Maya. Next, I have Dr. Christopher Lake. Please go ahead.
Great, thank you, Melinda. It's my understanding that HHS and CMS are going to put cybersecurity standards in conditions of participation for hospitals and healthcare providers coming up here real soon. So I would hate to put something as specific as high trust certification in there and then have that be a conflict with conditions of participation. So I'm kind of leaning more towards the broad generic language myself.
Great, thank you. Next, I have Chuck Podesta. Please go ahead.
Yeah, so I'm gonna echo my two colleagues here. Cybersecurity, the language within, whether it's HITRUST, NIST, HIPAA, the regs that are coming out for participation, they're all going to change over time. And to put something specific like, MFA, you've got multi-factor authentication. Yes, that's a tool. Yes, everybody should have it. There are going to be other tools coming out. Unless we're going to go in and revise this every 6 months or a year, it's going to very quickly become obsolete at some point in the future. So again, I just echoing my colleagues to, let's follow the guidelines rather than doing something specific.
Great, thank you. Michael Gagnon, please go ahead.
Yeah, I wonder if it can't be handled through talking about compliance with the best practice of security standards at the time, and put in more of the general. We have language already about complying with standards and such, and I wonder if it doesn't belong there, and we could keep it general, but still, make it also flexible, as Maya and others have said, because you get into small practices, they're going to struggle with this. Conditions of participation are only Medicare, as far as I can tell, and so I think maybe just putting something more general. Maybe we make a reference to CISA where we put HIPAA or other things, if that's but even that might evolve over time too. So I'm just concerned to making anything too specific. Maybe we just put something very generic about complying with the best practices and let the certification process be led by the director for all of this, which I think is what the regulation allows.
Great, thank you, Michael. I do want to recognize in the chat, Ashley Jonkey also put in, you know, can we say as consistent with federal law or current federal regulations? That might be an option there as well.
And before I know you're going to go on to someone else, I believe, and someone chime in, I believe that the CISA performance goals are the standard federal regulation. That's my understanding, but someone smarter than me might correct me.
So
Thank you. Let's see, I do see Lynn McAllister, you have your hand raised.
Yes, good morning, everyone. I just want to echo what Chris talked about because the Joint Commission and CISA have been collaborating. They have been putting out information on standards that they're working on. So echoing kind of what everyone is saying, I think being a little bit more on the generic and sort of leading forward with some of the language we might already have in there. So I don't know if we proceed forward a little bit and looking ahead, we do talk about securing mandates, federal. So maybe there's some basic language that we can put in there that sort of covers this.
Great, thank you, Lynn. Michael Kennedy, please go ahead.
So kind of what everybody's talking, we could use the NIST standards, which is kind of like the federal best practices. And I believe it's NIST 853, which is kind of like general. I might have to double check that number, but that's kind of like the federal best practices for securing, you know, data. And I can provide that one once I look at it in a little bit more.
Great, thank you. Yeah, we'd appreciate that. If you find it and you could put it in the chat, that would be great. All right, let's see here. Okay, so it seems like we have, you know, consensus leaning toward adding some language to speak about security standards in a more general sense. And let's see, as for where we would put that, I'm going to share my screen again. Get everybody over here. Okay. And so just to orient everybody, so this section of NAC is, you know, the requirements concerning electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, health-related information, and electronic signatures. So first, you know, we talk about what a health information exchange must be upheld to in this section. And so that's, you know, this first section is all about health information exchange. And then as we get into other sections, you know, then we go into like an HIE, right? Or not an HIE, an EHR, getting my acronyms mixed up. And then, you know, moving into, okay, you know, we have the HIE and the EHR, then, you know, these are the other provisions that where people must comply with these provisions of the bill by such and such date. And then we move into, you know, what meets those requirements. So wondering if we should just have another section within this section, speaking in those general terms about, you know, data security and what both an HIE and an EHR must meet for security measures. What do you guys think about that?
And I know, Melinda, to interrupt for one moment, I know you discussed sort of an overarching motion, you know, at the end, but I wonder if it would be helpful to break it down at least on some of these issues and have perhaps some sub-formal motions on like this particular issue. And I know we're gonna have another big one coming up in requirement number 4 for section B.
Sure. Yeah, open to that. Absolutely.
Melinda,
Eddie, you look like you want to talk.
Yeah, Melinda, to your point, I think a different section of requirements is great because I think it calls out sort of the broader emphasis that we are all, you know, asking folks to implement when using this health record. And so, yeah, I think a new section would seem to be wise. And again, the reason so I'm interested in everyone else's opinion. Like we can literally just say a standard CISA, that which is that, or NIST, or what other folks have been saying. I feel like if we put certain principles, or some of these core principles, and make those sort of like baseline, I know in reg it definitely helps anyone interacting with the state in any capacity with some clear guidance. It definitely shapes what that whether it's a provider or a technology provider or what have you. I think putting and calling out some baselines are good, but could we put in baselines and say, as well as updated standards from the Cybersecurity Infrastructure and Security Agency or something like that? Like, is that something that we could do?
Michael Gagnon, please go
I'm
ahead.
going to comment again. I'm not sure we need it, because if you look at that, see what section of the reg it's in, it talks about compliance with high tech. And if you do the reference into high tech, it already has a bunch of security and privacy standards as part of it. So Health Information Technology for Economic and Clinical Health Act, which is the first requirement under section B number 1(a), I think we're mostly still covered.
Yeah.
Are we not? I haven't read through high tech in a while, but I was just doing a quick Google search on that, and it looks like it does specifically call out many of the standards that are kind of all around the thing as you're talking about, Betty.
Yeah, and I just want to pause. I see Lynn McAllister. Please go ahead.
Yes, to that point, that's in there. So I think originally, like we said, the section 1 is a HIE that supports in the state. So maybe it's just copying this similar language with these standards and moving it into that extra section.
I see what you're saying. Yeah, so not just an HIE, but an HIE and EHR should comply with standards as associated with high tech, and then also be a member of TEFCA, aligning with the ONC. Would that be?
The second part probably doesn't need to be in there, but the first part does. You may not want to require that EHRs or practices have to be part of TEFCA necessarily. Right now, that will come as a federal mandate at some point. But the first part of that might fit nicely right under where you are here, B2 somewhere.
Yeah, I'm gonna do, let's do.
Because you're not talking about high tech in that section here, B2. And then you could make it generic to anyone participating, if you wanted to make it a new section like that, a B2 or B3 probably, right, at that point.
Yeah. Yeah, I don't know what section it is. I'll figure it out.
Yeah.
But so let's see, how would we say that language? Anyone for data security.
That covers it, makes it more generic to people generally, across all the potential connections to this and all the different organizations at this point.
Mm-hmm. So maybe we use this language. Anyone, because I wanted to, like with the electronic maintenance transmittal exchange. So any party involved in potentially, maybe we could use that. Let's see. Sorry,
Yeah,
apologies
I
for
like
the scrolling.
Can I ask while you're doing that to Michael, because then and Lynn, you both chimed in on the high tech, because we're referencing the high tech law, but it doesn't account for perhaps any new changes. I mean, I haven't seen a committee happen in states I work in that hasn't talked about AI and the needs for protections on AI, you know, in certain areas, or the use and viability of it. But I guess my question is, do we do this because we're mentioning HIPAA as well? Do we also put in there then CISA as a guiding framework? Is that we're getting too complex?
I'm open to that thought. Lynn McAllister, please go ahead.
Yes, I mean, since we sort of talked about either, you know, the NIST standard or the CISA standard, since we all sort of talked about adding it in, that we would add it on here, but I can certainly leave it to others to discuss their options.
Great, thank you. Dr. Lake?
Yeah, I just want to point out that CISA itself is a federal agency, not a policy document. So they write policy documents on everything from cyber to critical infrastructure. So if you're going to reference CISA, you better reference the specific policy number.
I see, thank you. Let's see, and then Michael Kennedy, I know you talked about there was a specific that potentially we could reference. Were you able to come up with that reference?
Yep. And thank you to the other Michael for confirming. It's 800-53. And
but that is not CISA, right? Like that is a different.
It's specifically NIST SP 853.
Because
is it NST?
NIST, National Institutes of Standard Technology, SP space 853 is the reference.
Okay.
It covers a lot, you know, because it's kind of a guiding set of core principles about a lot of things in security.
yeah, and it is updated regularly. So by referencing that document, it should be the most up-to-date version of it.
Yeah, they're already at Rev 5. I would not suggest we put that in here because it'll be Rev 6 before you know it.
Yes. Okay. So let's see. All right. So I hope everybody can see that okay. So we're adding this section in to clarify that any party involved in the electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, health-related information, and electronic signatures must comply with all applicable requirements of high-tech law and HIPAA and NIST document. Dr. Lake, do you have a comment?
Well, I just wanted to point out, you know, once again, we may be alienating some of those small providers. This might be a full-time job, just making sure you comply with all of these regulations and stuff. They're gonna, you know, purchase a suite, you know, for an EHR. They're gonna purchase that EHR, and they're gonna rely entirely on that vendor to make sure they're up to date. And those vendors are not gonna necessarily care what Nevada law is compared to everybody else that they're selling this to. So Nevada's a very small fish in the healthcare pond. So we don't want to be too overly burdensome that we maybe cut out half of the vendors and make it exorbitant for a small healthcare provider to comply with this.
Good consideration. I was wondering if an EHR certified by the Office of the National Coordinator, if that would meet these standards by having that certification, or are we adding on things that are already included? You know what I'm saying? Does that make sense?
They certainly comply with high tech and HIPAA. I'm not exactly sure if all of them go all the way to NIST SP 853.
Yeah.
There's so many of them. It's a little hard to keep track of all of that. But we could look up the certification rules.
Yeah, it may be hard to determine if they're following it, but 853 really is kind of a baseline. So if your EHR doesn't meet that, I mean, that's kind of a problem with the EHR you picked, and it's federally recognized, not just Nevada state.
Okay, so we may already have those standards met through, you know, the how we've defined an EHR and an HIE. Maya, I see you have your hand raised. Please go ahead.
Sorry. Yeah, I just wanted to echo Mr. Lake. I think the, you know, looking back at the legislative intent was really that all practices could participate in this. So just being, you know, concerned if we are being administratively too burdensome for those smaller practices.
Yeah, absolutely.
Eddie,
do you have additional comments?
Yeah. So I was reading, I went through NIST and I get it. So like, when I was sort of mulling this over and just for the team's edification, I've been thinking about this for a couple of weeks. I had something sort of similar designed for the last meeting before we pivoted. My thought was if we can at least set a baseline, right? You know, at a minimum, these things need to be sort of observed. When I dug in through like CISA, the reason I didn't come with language that says, let's follow CISA guidelines or performance goals, because CISA is so big, right? It's this ginormous guide and there's so many pieces to it that might not even affect, you know, electronic health record in many situations. And so I get the simplicity of just putting in these acts in here and then the reference to NIST but NIST is, I mean, that is a ginormous document. And while we will get to the goal of protecting that record, yeah, are we jeopardizing small providers that might not be able to, let's say, purchase a system to the extent that NIST
So
I think you're right, Eddie. It seems to be overkill when I look at it now. All certified EHR technology has to comply with high-tech, but only federal systems have to completely comply with NIST SP 853, and that may not be, you know, some of all practices or all organizations in the state. So I think we're getting maybe too specific and just let it stay at what's required for high tech. And honestly, I'm not even sure every provider in the state will have a certified EHR technology. I mean, you know, there's the broader we get and the smaller organizations we get and the ones that are not, that didn't have to get through meaningful use because they weren't taking money from the federal government. Still, we want them in this network and they may not be in compliance. And the way we usually handle things like that when you're connecting to networks is you have a security accreditation questionnaire you make people fill out to make sure that they're following certain guidelines. And I think we're kind of trying to be prescriptive, which is not necessarily a bad thing, but it really is a moving target and hard to define in a regulation. And I think we just have to leave it general and recognize that, you know, if they were connecting to one of the national QHINs, they would have to follow certain rules about that connection and what they did, or they were trying to do interoperability in another way. You know, I think you got to be flexible. So I'm not even sure that this SB 853 is actually a requirement, but it might be, you know, guidelines for things. So, you know, it's complicated.
Yeah. I did want to make a comment too that, you know, by having an electronic health record system that has to be, you know, certified by the ONC for high tech, and then also having the HIE that has to be a member of TEFCA should already meet those data and security requirements through those requirements themselves. So again, I think that it's important, you know, to think about the smaller providers, and if they're already meeting one of those two things, then I don't want to add anything else on them, but I'm open to, you know, your thoughts and comments. So Lynn McAllister, please go ahead.
Yes, it's really challenging because we all want to keep this open for our smaller providers, but in the same sense, we're trying to protect the overall people of our state too with their security data, knowing how easily and quickly people can make bad use of that information and sort of weed their way through systems. So it's a tough one, and I absolutely see where we want to add language that protects that, but in the same sense, not wanting it to be so broad that it can't be maintained. So I go back to section B, requirement 2, where we have number C, where we do have high tech. So this is about the EHR systems, ensuring compliance with high tech, HIPAA, and other applicable federal and state law.
Yeah, good comment, Lynn. Dr. Lake?
Yeah, just an observation. Are we even sure that the state of Nevada's hospitals or public health clinics meet the requirements of NIST SP 853? Because we might even be putting a burden on the state of Nevada with absolutely no authority or no budget to make that their systems comply with this.
Good comment. Thank you. Michael Kennedy, please go ahead.
So sorry, I'm just thinking about that last question. So it's impossible to say without doing an audit of every hospital, but it is 853 is kind of a baseline, and I'm just kind of doing some Google searching, and although I haven't been able to find an exact crosswalk between high tech and NIST 853 quite yet, what I'm seeing is that if you are high tech compliant, you would be 853 compliant. So I mean, it may be bogging it down by adding another requirement onto it, but I think in actuality, if we're requiring high tech compatibility at least, or 853, it's probably mostly going to come down to saying the same thing in different ways.
Okay. Thank you. All right, so given all this discussion, I propose that we take this section out and keep it as our requirements for the EHR and requirements for the HIE and meeting the general federal requirements associated with data, information, and security. Right, I'm going to save this language just in case, but
I think you said it well, Melinda. That's probably correct at this point. I don't know if you want.
I know, should we
ask
call for
a motion or people to comment?
for a motion? I'm willing to entertain a motion.
Just so I'm clear,
Yeah.
can I ask, we found this existing already in the HIE and EHR? Is that what
Yes.
we're saying?
Yes.
Yeah, compliance with either a certification process or high tech, which covers everything I think you talked about, Eddie Plus. So I think we decided that we already have the references.
I'm just looking. Okay.
So Melinda, I'm sorry, this is Ashley. We'd be getting
Sure.
rid of the requirements under 2.
We basically we're keeping the requirements in 2. So this was an additional
I see.
request to, add in those other the federal requirements on top of the federal requirements that are already required of an EHR and an HIE. And so the group discussed that, we've already got those standards included in the language as is. So did not feel the need to add additional, language burden in the draft regs. All right, willing to entertain a motion if anyone would like to make a motion to keep this section without the additional language proposed.
I would move that the current high-tech references cover the security and privacy requirements that we have just been discussing, and that no additional language for that is required.
Great, we have a motion. Do we have a second?
Chris Lake will second.
Great. Any discussion? All right, all in favor, say aye.
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 All opposed? All right, motion passes. Okay. Now we will move on to section B, requirements number 2. So as a reminder, this language outlines the requirements for an electronic health record system that is in alignment with the bill language in items A through D. So pausing here, so members have a chance to review the language, and please speak up if you have any comments, questions, concerns on requirements number 2 here. All right, I'm going to move on to requirements number 3. So requirements number 3 starts out in item 3 as noting first that the exemptions that are documented in Assembly Bill 7, which are denoted by X's here since AB 7 is not yet codified to NRS, and then continues with items A through C, stating the specific groups that are called out in section 2.8 of AB 7 to adhere to the requirements by a certain date. So again, pausing here to give members the opportunity to review the language and speak up with any questions or concerns.
Aren't these specifically called out in AB 7 this way
Yes,
in the statute?
in the statute.
Yeah, okay.
Okay. I'm going to move on to requirements number 4. Okay, so requirements number 4 specifies the choice in compliance requirements that the above groups are held to per the requirements of the bill. The group did receive a letter from Senator Fabian Dignate, chair of the Joint Interim Standing Committee on Health and Human Services, detailing his recommendations for the advisory group to consider that are specific to this particular section. And he recommended the removal of item B entirely. There was also public comment during the meeting of the Joint Interim Standing Committee on Health and Human Services this past Monday regarding the same topic, which has also been sent to advisory group members for consideration. So I would now like to open the floor for discussion on this section so that we can hear from the members of the group on their thoughts given these recent comments. And Maya, I see you have your hand raised. Please go ahead.
Thanks, Dr. Southard. Yes, and I also just want to clarify, I did make comments in Interim Health and Human Services on behalf of the Culinary Health Fund. I'm the Health Policy Director for the Health Fund. It was not the union. I made the comments because we very closely followed AB 7 through the Patient Protection Commission and the legislative session, and we also provided testimony on the bill. And we really, our comments are reflecting that we really want to ensure that the proposed regulations do not exceed the department's scope of authority established under the statute. And we think it's really critical to review, maybe you guys already have, but to review the legislative record and intent of the Patient Protection Bill. And the intent was really for patients to have direct access to their electronic health record from their providers. And the language specifically states that. And then of course the interoperability side of it. So our concern today is that Section B requirement 4 is proposing that compliance can either be met by having an electronic system or connecting with the health information exchange. And we don't believe the connection to an HIE that reflects the statute or reflects what's in the legislative record, and it should not be an alternative to having an interoperable electronic health record systems. So we think this language is actually in direct conflict with the provisions of Section 1.08 in AB 7 and the legislative intent. So that's why we've made our comments, and we're hoping that the committee, and also when this goes to LCB and others, that they'll really ensure that all of this language is not exceeding the scope of authority to the department provided by AB 7. So thank you for your consideration on this.
Thank you for your comments, Maya. Appreciate that. I also wanted to just ask that, this is saying that a health information exchange has to meet the requirements that we already outlined in subsection 1. And so just ensuring that those requirements still do not meet, in your perspective, the requirements of the bill. I just want to clarify.
Sorry, I'm not understanding what you're asking in regards to section 1.
Sure. So section 1, because it says, maintain connection with a health information exchange pursuant to NAC 439-576 subsection 1, which is this particular health information exchange that we have defined up here, that must be a member of TEFCA and, meet these additional requirements. It has to be that specific type of health information exchange that would meet the requirements of the bill, is what the regulations are saying. So I just want to clarify that your perspective, that it does not.
We don't believe that section 4 as it's written is in compliance, because it appears to be making it either you have an EHR or you have a connection. And so that the focus of the bill and what the language, it was never raised that having an electronic health information exchange would be an alternative to having an interoperable electronic health record. That, and I think the language is very clear. I mean, it says there's supposed to be a framework for allowing patients to access their electronic health records directly from their healthcare provider.
Correct. Thank you, Maya. I just wanted to get that clarification. Pausing for further discussion from the group. Michael Gagnon, please go ahead.
Yeah, I believe that comment is not accurate for what we are attempting to do, and that this does meet all of the requirements. Connection to a health information exchange can enable the exchange of information on behalf of the patient. No one collects their information directly from a provider. They always do it through a business associate, and business associate agreements have been established with health information exchanges to perform services on the behalf of providers. The concept that somehow we will get patients to log into a patient portal, numerous of them actually, to collect all their records and somehow be able to exchange those records or perform other public health initiatives as required under law, is just not going to be a reasonable thing. It just does not preclude patients from connecting to their healthcare providers, or for that matter, to the HIE, which has their own patient portal at this point, and still allows for the connection and movement of records around, but actually does so in scenarios that I think greatly improve that requirement. Now, I have to say that if you think a patient is going to log into a portal while they're unconscious in an emergency room and get their records exchanged from 3 or 4 places, that's a significant issue and a significant patient safety issue. And we talked about that during this committee, and I think we've created a regulation here that meets the requirements of the patients being able to access their records, but also takes into account all the other things that are needed for interoperability in the state. It does recognize HIEs in the statute. As a matter of fact, it requires even the national networks to be called HIEs according to their definition. And they must require and follow the rules that are just explained. So I think connection to an HIE is a way to make it an easier way for providers to meet the requirements. They can connect to the HIE, their data gets exchanged, it gets moved around. The patient can simply consent to having their data moved, and the data moves automatically on behalf of that consent. And so that's the intention. The intention is not to limit access or to make only one way to do this. That honestly is going to impact patient safety, but rather to allow for all the things that are in the statute, but still enable an interoperability framework, which was the first part of the sentence. So I think we've met that here. And I think not only do we met it, but we've enabled something that really becomes a service to all the patients and providers in the state.
Thank you, Michael. Appreciate those comments. Lei Zhang, you also have your hand raised. Oh, I can't hear you for some reason.
Can you hear me now?
Yes. Thank
Okay,
you.
sorry. Our question is, if we remove 4B, and then how can we make sure the system interconnect for the data exchange, for the information exchange? I know is the first 4A, just make sure every provider have the certified the EHR system. If the EHR system not connect to certain network, maybe not necessarily HIE, but certain network for the information exchange. So we back to original, we lost the purpose of this bill is each provider have their silo system. For public health purpose, we cannot get comprehensive information from different provider. We have to talk to each provider, say, can you provide information for this patient? We can hospital B, clinic C, and get those information. We need to make sure the system get connected to each other and also perform the data information exchange. So I don't know how can we change the language. I just want to make sure the information are exchanged through a certain network.
Thank you for those comments, Lei. Does anybody on the advisory group have a response to that? I'm hoping somebody else has more because I'm not the expert. Maya, please go ahead.
I would just add, I think the issue that Mr. Gagnon raised on emergency situations, I think that's covered in existing regulation. I don't believe we're touching upon that here and that's being altered in any way. And to Mr. Zhang, I would just, again, I think the purpose of the bill and the legislative record and the testimony was really focused on patients having direct access and ensuring that they can do that. So just making sure, I'm raising this, that we're making sure we're staying within those parameters.
Thank you, Maya. Appreciate that. Michael Gagnon, please go ahead.
Yeah, we are, the emergency access thing is that a patient can't take action to move their record to someone during an emergency. It said, yes, it calls out that what can happen, what's the procedure in the case of an emergency. But practically speaking, the record isn't there and the patient is not in any position to send that record at that point. My point is that only a patient-directed exchange does not solve all the problems. We're not precluding patient-directed exchange in this. It does meet the requirements that have said in AB7. We're just saying that there's more to it. If you want to create an interoperability framework, it goes well beyond just patient-directed exchange. And honestly, only about half of patients are offered or regularly use portals or other methods for doing exchange. And only a small percentage of them actually know how to exchange data across different electronic health record systems. I can tell you from practical experience, it is not easy to do that. It is quite complex. It's not terribly difficult if you're doing it from within the same vendor EHR. If you're doing everything within Epic or everything within Athena, it's not terribly complicated to move records around, but it gets very complicated if you try to move them from Oracle or Cerner or Epic or something else to one another. And you're not going to do that in a way that provides that during the case of an emergency. The other issue is that this really impacts our underserved communities and our elderly, those who are highly unlikely to use those EHR-based portals because of technology inabilities or their inability to have the right way to gain access. I think if you don't put the kind of interchange we mentioned in this, you are impacting patient safety.
Thank you, Michael. Dr. Lake, please go ahead.
Yes, thank you. I don't see this as necessarily a mutually exclusive type situation. Could we change the or to an and? And that way the patients would have their access. And it's just a question, not a suggestion. But that way the patients would have access to both systems without it impacting. I hear what Michael has been saying, and I think a lot of people in Nevada here are actually going to opt out instead of opt in, and actually do like those portals where they can go into LabCorp and get their own data, or go into their private physician and get their own data, as opposed to an exchange. So I guess if that, I didn't participate in the session, and I'm not sure what the legislative intent is, but if that truly is the intent, then we need to appreciate that as well.
Yeah, thanks, Dr. Lake. I appreciate that. And we had actually had that same discussion. I can't remember which meeting it was, but the bill specifically calls out that you cannot require anybody to connect to an HIE. So that's why we had to have the or language here to note that it is a choice. You can have an EHR that meets these requirements, or you can have an HIE that meets these requirements to maintain that interoperability, but we can't require somebody to connect to an HIE. And then Michael Gagnon, please go ahead.
Yeah, I was going to say that again, that's why we put the or there. And we are not saying have an EHR. We're saying have an EHR that also has installed and implement the components or services for exchanging data. It's not subtle. It's actually a really important point. And we had a whole discussion about this, because having an EHR does not immediately make you do that. Regardless of what your HR vendors tell you, there are definitely add-on components you must have to make that work. So if a provider group, as the sentence above says, you know, the section above says practice more than 20 must comply with subject. If you read that, it says you must be able to exchange data. This was specifically put in 4A, written that way, so that you don't just have the EHR, but also install the components so you can push data out of your system to something else. It's an important distinction. But the other way to push data out of your system is to connect to a health information exchange, which does that on your behalf. That's what these two things are saying. And I think we have to have both of those to make interoperability work.
Thanks, Michael. I also wanted to ask, on the HIE component, does the HIE allow direct patient access to their records?
Right now, the HIE is implementing a product called Selfie, which does allow the patient to view their medical record, forward their medical records. It will soon be able to let a patient sign their consent form online. It uses authentication so that it knows who the patient is, and it does allow for the exchange of records, and it does that across multiple settings, meaning it's everyone connected to the health information exchange. You see your record across all of those settings instead of having to go to multiple different EHRs to accumulate your own record.
I see. Thank you. Maya Holmes, please go ahead. Oh, I think you're muted.
Sorry about that. So I was just going to add, I know I sound a little bit like a broken record on this, but I think, again, the goal and the legislative intent and the testimony really reflects its direct patient access to their record from their provider. I don't think the language could be more clear. And the goal also in the legislation was really to move providers to be interoperable to health records, because we recognize not everyone is there at that point. And so that's why there was a gradual ramp up for smaller providers and the waiver process and the appropriation to help people move in that direction. So again, just that we should not be exceeding what was permitted in the statute or the intent of the statute.
Thanks, Maya. Eddie, please go ahead.
Thanks, Melinda. So just reading the language and going back to the bill, could we fix the conversation we're having today? I know the word either in the top sentence of 4 might create that sort of dichotomy between these two. And could we strike either by the follow, so either of, and just do by the following, and after A, instead of or, do and may. So at least you're like, it seems like the EHR is the base that the legislature wanted. Adding on the HIE to it is sort of secondary to the nature of what we're trying to accomplish. Not secondary, it's and it helps, it adds to it, but it is not the only thing that perhaps the legislature wanted. And so by doing either and then putting that or, I think that's the concern when the letter I read from Senator Donate, and I reread that, perhaps this simple change could get to that.
Thank you, Eddie. I put those in yellow highlight on the document here. Let's see, Michael Gagnon, please go ahead.
We're discussing how the provisions are met. And the provisions include 2 different things. One is, access by patients, and that's not disallowed here. And we're also talking about how do you exchange data? How do you push data out of your system to another system? I think that's what's being said, where what those provisions are meant to be. And so I don't see how the argument around access to records is limited. There's no limitation on access to records by maintaining a connection, or by, and you have to have an electronic health record of some sort to maintain an electronic connection by a patient, right? And so at this point, I'm not sure there's much to be changed.
Thank you, Michael. I did start sharing a copy of the bill just for the group's reference. The components that we're discussing right now are in section 1.08. And it's in section 1, subsection, oh gosh, I think it's like 1(1)(a)(1)(1). So basically, saying that the use allow patients to access their electronic health records directly from the healthcare provider of the patient and forward such electronic health records electronically to other persons and entities. And I just want to clarify, Michael, are you saying that the HIE, as we have defined already in the draft regulations, that specific HIE would meet this or no?
It would meet that.
It would, okay. Okay, and then Maya, I see you have your hand raised. Please go ahead.
Yeah, I would just suggest that, we support Senator Donate's proposal to actually strike the B in the language, because we agree it exceeds AB7. And I really appreciate Mr. Ablazer's recommendation, but I don't think it's necessary, because and may, that's already a given, right? Providers can join the HIE, facilities can join the HIE if they see the need. That doesn't need to be a part of this regulation. And it's not, the HIE was never specifically recognized or sort of recommended during the bill process as having a role. It's being spelled out, it's having a role. The focus was on the interoperability, starting with the interoperability of the electronic health records and moving providers in that direction.
Thank you, Maya. Michael, please go ahead.
Yeah, let's be clear. This is not Healthy Nevada we're talking about. This is health information exchange. And all HEFCA HUHINs are health information exchanges according to the statute, the way it's written. Okay, so that's what it says. And so we can't get rid of that. And yes, it is part of the requirements that are in there. The point is that if we want to make a truly interoperable health network, we need to keep the regulations we have talked about, not go back to what was, we haven't limited what was intended. That's my point. What was intended is here. Striking HIE just creates an environment where we allow only EHR vendors and patients to be the solution. And that is not what we are trying to do with an interoperability framework. We're trying to solve all the problems, not limit the solutions that are in place. I would like to make a motion that we strike all of these changes in this, and we accept this language as is. That's what the committee came to.
Okay, we do have a motion on the floor. Do we have a second?
I second.
Okay, we have a second. Do we have any discussion? Okay. Hearing no discussion, I'll call for a vote. All vote. All those in favor, please say aye.
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 All opposed?
Opposed.
Thank you. All right, motion passes. So we will keep the language as it was previously. Going to, actually, I can just undo all of these. Okay. All right, we will move on now to the next section. So next, I did just want to cover that NAC 439.578, outlining the Health Information Exchange, or HIE, application and renewal of certification. So that section there, and then NAC 439.582, outlining the HIE administrative hearing guidelines. Noted here remain as the original regulation text that was adopted in 2017, still in effect today. So no changes are being proposed to these two sections of NAC at this time. Just pausing for comment before we move on. Okay, I'm going to skip down to section C, duties. To include text in item 1A to provide for additional flexibilities as granted under state or federal law. So again, I'm going to pause here for a moment for the group to review this language as it was previously discussed with the group, and any comments on the addition. Okay, I'm going to move on. So again, noting here the NAC 439.586, outlining the additional duties of the HIE, remains as the original regulation text that was adopted in 2017, still in effect today. No changes are being proposed to this section of NAC at this time. Any comment before we move on? Okay, I'm going to move down to section D, prohibited use. So the group included similar language under item 1 and item 3 as were used previously in section C, duties, to provide for additional flexibilities as granted under state or federal law. And again, pausing for a moment for the group to review and comment on these additions. Oh, Quinn, Polly, did you have a comment?
No.
Okay, perfect. Thank you. All right. I'm going to move down to section E. Let's see, actually this one. So we do have a couple, NAC 439.592 regarding patient control of access, and NAC 439.594 regarding submission and retention of complaints, which is down here. Sorry for the scrolling. And then NAC 439.596, outlining duties of an HIE if confidentiality of information is breached, All those sections remain as the original regulation text that was adopted in 2017, still in effect today. So no changes are being proposed to these sections. So pausing for any comment on these sections before we move on. Okay. So next we have section E, waiver, outlining the option for a provider to request a waiver to these provisions if certain criteria are met, per language contained in Assembly Bill 7, found in section 1.08, subsection 6. So just pausing here for a moment for the group to review and comment on this section. Okay. I'm going to move down to section F, inapplicability. So this is outlining where certain provisions are inapplicable per the language contained in Assembly Bill 7, section 1.08, subsections 5 and 7. Pausing here again for a moment for the group to review and comment on these additions. Okay. So now that we've gone through the entire document of the draft regulations to fulfill the requirements that are set forth in the bill as pertaining to this advisory group, I would like to pause for any comment or discussion on any section of the draft regulations that we've reviewed today, and happy to navigate to previous sections for the discussion if we would like. So Lei Zhang, you have your hand raised. Please go ahead.
I may not get the latest version. I get a PDF from you last Friday. They have one section talk about requirement for a contract statewide HIE health information exchange. Does that is part of this draft?
Right. So Lei, I apologize for any any confusion there. The documents that I had sent out last week were meant as additional supplementary materials for the meeting. Those included all suggested language that I had received to date. So I wanted to give the advisory group the all the information, suggestions, language changes that have been received by DHHS in support of these regulations as we've moved through this discussion. So the language as I'm presenting today is the current draft that we're working on.
Thank you.
All right, and Maya, please go ahead.
I was just gonna, I think I've already, stated our concerns regarding the regulations. We're gonna need to vote not to support the recommendations because we do not think they are consistent with the statute or the legislative intent.
Thank you for the comment, Maya. Okay, any other comments? All right, so with that, I will entertain a motion to approve the draft regulations document you have before you today in advisement to the director of the department in the adoption of regulations pursuant to NRS 439.589 as amended by section 1.08 of this act. Do we have a motion?
I move to approve.
Thank you. Do we have a second?
I second.
Great, thank you. We have a motion and a second. Any discussion? Okay, all in favor, please say aye.
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 All opposed?
Opposed?
Thank you. Motion passes. All right, so now that we have an approved draft regulations document, the Division of Healthcare Financing and Policy will submit this document to the Director of the Department of Health and Human Services for review and approval. Once Director approval is obtained, the division will submit the draft regulations to the Legislative Counsel Bureau, or LCB, to initiate the permanent regulations development process. And then in rounding out this agenda item, I wanted to share with you all an overview of the proposed timeline leading up to regulation adoption. And so this is one of the slides that I shared with the Joint Interim Standing Committee on Health and Human Services. So getting these draft regulations approved by this group in advisement to the DHHS director was the first step in the process. So in moving forward with the permanent regulations process, we will be initiating that with the LCB review over here. So following submittal to LCB prior to June 30th, the division plans for the following activities related to regulation development in the remaining 2024 timeline. So July, the division will be conducting the required survey of impact on small businesses. August, the division will draft a small business impact statement and post it along with the public workshop meeting notice. We're going to hold the public workshop in compliance with open meeting law and post the notice of intent to act upon regulations 30 days prior to that public hearing. Then in September, the division will hold the public hearing in compliance with open meeting law. October, division will submit to LCB the agency approved regulations, the informational statement, the form for filing administrative regulations, and the notice of adoption of regulation. And then lastly, in November, we will seek approval by the Legislative Commission. And I did want to note here, I did put a star here because it is recommended for these regulations to go before the Joint Interim Standing Committee on Health and Human Services prior to seeking approval from the Legislative Commission. So we will work on getting on that agenda as well. I will be sure to keep all members of the Electronic Health Information Advisory Group apprised through email for each of these steps, including all public meeting notices and attachments. So please feel free to reach out or ask questions as they come up along the way. And please forward the information out to your contacts so we ensure the widest reach possible in notification and participation of all steps in this permanent regulations development process. So at this time, the advisory group has met its statutory requirement to advise the director of the department on the development of the regulations adopted pursuant to NRS 439.589 as amended by section 1.08 of AB 7. Additional meetings of this advisory group regarding advisory to the director of the department on the implementation of the regulations will be called on an as-needed basis going forward. So I will be in contact with you all as we look to start those meetings up. Any other questions?
Melinda, just before we adjourn, did you call for public comment at the conclusion of this meeting?
I will. That is
Okay.
next on the agenda.
Just want to make sure everyone has one last final say, one last opportunity. Thank you.
Absolutely. Any other questions or comments? Okay, with that, we will, oh, Lei Zhang, please go ahead.
Linda, could you go back to the page 2? Is I just want to make sure the one touch point I didn't miss it. So the page 2 is 439.5761.
This one?
Yeah, and then go 7. Can you go scroll down a little bit? And then hold on here. Yeah, here. Provide services, population, enterprise, interoperability, whole national. And could you scroll down more? I'll go down. To, I think it's that's why yeah, I'm fine.
You're okay?
I'm okay. I'm okay. Thank you.
Okay. No worries. Thank you. Okay, we will go ahead and close out agenda item 5 and move to agenda item 6, which is public comment. So
And
no
Melinda-
action. Oh, yep.
Sorry, Melinda. As part of this public comment, will you make sure that the discussions and the comments that made in chat are included as part of the public comment to this meeting?
Yes. I apologize. Oh my gosh. Okay. So public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included as an agenda item for action. Comments will be limited to 3 minutes per person. If you would like to provide public comment, please raise your hand utilizing the Teams platform, or if you are calling in, please press *5 to raise your hand. And just prior to that, I'm going to go ahead and read the comments in the chat into public comment. So in chat, we do have reference to CISA.gov, which is the information that we were discussing previously in section B, requirements number 1, or yes. And then we were talking about, let's see. And then we had the NIST SP 800.53 reference would be a good reference in our standards section. Then Michael Kennedy had noted, for everyone's information, NIST, or the National Institute of Standards and Technology, is essentially the federal government standards for computer system operation. Lynn McAllister shared a link to the NIST 800-53. And Sarah Bradley had noted, just for the record, I joined the meeting at 9:15. Sorry about the delay. I had an issue getting the computer going. Totally understandable. And then we have Bobette Bond. We really do need to make this work for small providers and vendors. The regs should not be too constrictive to achieve. The main questions in the assembly hearing were to make sure we help the docs to do this and make sure the patients can opt out. AB7 does not anticipate that connecting with an HIE. An HIE already exists in statute and it regulated in statute. This bill was created to ensure patients do not have to use an HIE. What Mr. Gagnon is asking for far exceeds the statute. This is intended to support the creation of a patient and physician exchange. The bill specifically prohibits requiring an HIE, so why would a regulation include it? Patients want to get their records electronically sent from a doctor to a patient or a doctor to a doctor, not to go through an exchange. That is the statute that was created. HIE is not in statute at all other than to be excluded. Can we get something in writing, Mr. Gagnon, stating that a patient is able to get their records directly from your HIE and is able to send them to where they want through your HIE? And what would it cost a patient since the HIE charges providers to participate? And then Michael had responded, I can provide information on our new healthy patient service. There is no charge for providers or patients. And Bobette had replied, what is the status of your new healthy patient service? And so with that, I'm going to go to public comment. And let's see, I see Bobette Bond, you have your hand raised. Please go ahead. Bobette, if you're speaking, we cannot hear you.
Thanks. Can you hear me now?
Yes.
Okay, thank you. Yeah, I think I filled up the chat with our main concern, but I'd like to be on the record. Thank you for having the DAG on this call to state that I do believe that these regs went down a road that is not anticipated in AB7. I was part of AB7. Senator Doniate's comments were because he was part of AB7. We were involved in the testimony of AB7. We were involved in hearing patient concerns about AB7 and assembly questions. And the HIE entered the regulatory piece of this body without the statute in mind. So I'd like this to be reconsidered, and thank you for your time.
Thank you for your comment. Lei Zhang, you have your hand raised. Please go ahead.
Melinda, could you go back to the page 4? I don't know.
Sure. Okay, so what section are you looking at, Lei?
Can I share my screen? Or maybe I get different version.
Yeah, let's do that.
Let me share my. Can you see my page? I'm not sure.
Yes.
This section, is this including the final version?
No, so
okay.
I apologize for the miscommunication there. So these documents were included again as supplementary documents. This was just draft proposals that the department had received for discussion of this group. And it is the feeling of the department to keep the the discussion focused on the bill language itself and the intent of the bill. And thus the requirements for the contracted health information exchange were not included in the draft regulation language considered by the advisory group.
Thank you. I feel better. Thank you.
Okay. Absolutely. Any other public comment?
Just quickly, we're continuing to get more comments in chat. I think it might be better for people to make their comments, via audio or telephone, computer, whatever, so that anybody listening to this discussion can hear the entire comment.
Yes, thank you, Gabe. I will continue with public comment noted in the chat. Michael Gagnon had replied, the HIE is not excluded. The requirements for providers to connect to an HIE is excluded. And then we have a comment from Aaron Fricky. I believe the representations regarding the legislative history are inaccurate. AB 7 does not require online patient portals linked to EHRs. If the legislature wanted to require that, then it easily could have simply said so, but it didn't. Instead, it utilized more flexible language for compliance. The EHIAG has wisely proposed a regulation that remains flexible and agnostic as to what networks and technologies, example, closed or open EHRs, server hosted, remote hosted, cloud-based, etc., providers use to comply with AB 7's requirements. This is a wise regulatory approach. The proposed regulation should give providers and patients options to protect their right to privacy, as well as access to up-to-date medical information essential for patient care. And again, I will pause for any additional public comment. Okay, hearing none, we will go ahead and close out that agenda item and move on to adjournment. And I thank you all so much for hanging in there today and your time and the discussion. It was very valuable. I really appreciate everyone's participation. Thank you so much. Have a great day.
Thank you.
Thank you, Melinda.
Thank you.
Thank you, Melinda.
Thank you.